We have an exciting session on new paradigms in glaucoma, and we have Professor Clement Tham here. No, um, he was there. Um, anyway, we can start. It's a small hall, and compared to the very large halls with very few people, but I think we can have a more interactive session here. So maybe we can begin with Professor Arthur Sitt on his talk, which is extremely important about episcleral venous pressure and its management in practical life.
The slides, please.
Okay, well, thank you, everyone. It's a real pleasure to be here. So I'm going to talk today about application of episcleral venous pressure management in practical life. These are my disclosures, and I have worked with a few pharmaceutical companies who have interest in EVP. So when we think about EVP, it's useful to first talk about the anatomy. So the conventional outflow pathway, as you all know, starts as aqueous humor passes the trabecular meshwork into Schlemm's canal, and from there it goes into the collector channels, and then into the aqueous veins, and then into the episcleral vessels. And the pressure in the episcleral vessels really forms a floor, which limits how low intraocular pressure can go. And that's shown as clearly to us by the modified Goldman equation, which relates intraocular pressure to the rate of aqueous humor formation, uveal scleral outflow rate, outflow facility, and episcleral venous pressure. And you can see that episcleral venous pressure stands alone there in that equation. So first, how do we measure EVP? So measurement of EVP is a little tricky, actually. So we have to have a device that places a clear silicone balloon on the eye. It ramps up the pressure and collapses an episcleral vein, and we video that as it's happening, and we also measure the pressure while it's happening. And then we take those images and we do some image processing, look at the brightness profile across the vein, and then we can look at the change in brightness as that vein collapses. And using this information, we can then go back and calculate the point at which the vein just starts to collapse. And that's actually what corresponds to episcleral venous pressure. So we can measure it. So we can then start to think about what are the things that regulate and change episcleral venous pressure. So one thing is body position. So this is a study that we did a few years ago. With a group of volunteers, young volunteers obviously, because they had to get into this rather uncomfortable position at the slit lamp. And we compared EVP in this position versus EVP sitting upright. And what we found is that when the subjects go into a semi-prone position, their IOP goes up from about a mean of 11.4 to a mean of 13.1. But then their EVP goes up as well from 6.4 to 7.8. And that change in ILP is about the same as the change in EVP. So based on this, we think that the positional change, at least in the steady state, the positional change in ILP is due to the positional change in EVP. Now, intraocular pressure in aqueous humor dynamics also undergoes a circadian variation, and most dramatically, aqueous humor formation drops by about 50% at nighttime. But EVP has a lot of variation, but on average, the mean EVP is no different from the mid-diurnal period to the mid-nocturnal period. Daytime about 7.44 mean, and nocturnal 7.41. But if we look a little bit more carefully, instead of just those 2 time points, if you look at the diurnal period from 8 a.m. in the morning to 4 p.m. in the afternoon, we know that ILP has a diurnal pattern where ILP starts out higher early in the morning and decreases over the course of the day. It turns out that EVP also has a diurnal pattern where it starts out higher in the morning and decreases over the course of the day. And so from this, we surmise that change in IOP over the course of the day is largely, but not completely, explained by the change in EVP. So EVP clearly is influencing ILP through its circadian rhythm. So how does the EVP actually change? Well, there's a couple ways. Well, one is you can dilate episcleral veins, and that definitely lowers EVPs to some degree. But it's a little bit complicated because there are also these arteriovenous anastomoses between the arterial episcleral vessels and the venous episcleral vessels. And you can imagine if you were to dilate these arteriovenous anastomoses, you end up arterializing the venous side. So dilation of those vessels actually raises EVP. And that was shown to us by Jeff Keel in rabbits, where he had nitric oxide donor, nitroprusside. So nitric oxide, of course, is a vasodilator. So if you give that to rabbits, it causes an increase in episcleral venous pressure, whereas if you have L-name, so that's a nitric oxide synthase inhibitor, so it increases the amount of, or decreases the amount of nitric oxide. And if you give that, then EVP actually decreases. So that's consistent with the idea if you dilate too much of the anteriovenous anastomoses, you're going to actually increase the pressure. So, in humans, though, there are other studies. So in rabbits, one of the things that, again, Jeff Keel showed is that proparacaine can decrease episcleral venous pressure. Pretty significant drop in rabbits if you use their system where you take down the conjunctiva, place proparacaine on the eye, and measure directly with an invasive procedure to cannulate the vessels. We tried to replicate this in humans, though, and we found that if we took a group of healthy volunteers, soft contact lens wearers, so that we could measure their EVP with and without anesthetic, and they're used to having things touching their eyes, we found that application of proparacaine did not change EVP. And so that was a little bit different than rabbits, but of course in humans we don't take down their conjunctiva before applying the topical anesthetic. Phenylephrine is a vasoconstrictor, of course, and what we did find, though, is that application of phenylephrine does decrease episcleral venous pressure in human subjects, and that's consistent with the idea that if you constrict the AVAs, then you're going to reduce the arterialization of the venous sides and reduce episcleral venous pressure. How about glaucoma medications? So in rabbits, it's been shown that brimonidine can decrease episcleral venous pressure. We haven't looked at this in humans yet, but we have looked at other medications. Notarsidol in particular is primarily a drug that works on the trabecular outflow system, so at the trabecular meshwork, improving outflow facility, but also reducing episcleral venous pressure by, again, dilating those episcleral vessels and reducing EVP by about 1 millimeter of mercury. And then there's other drugs. There's a new drug being developed called from QLaris Bio called AIOS2025-GP166-Changing. It's based on a ATP-sensitive potassium channel opener called levchromacalum. And what's really interesting about this drug is that it doesn't affect, it lowers RLP, but it doesn't affect outflow facility, uvoscleral flow rate, aqueous humor production, but it does lower episcleral venous pressure. And so it seems like this new drug in development may be the first drug that actually directly targets episcleral venous pressure. The trials in humans still need to be performed, though, and there's a version of this drug called QLS-111, or QLS-111, which is currently in clinical trials. So, knowing that we can that EVP is regulated and we can modify EVP, when is EVP reduction potentially most helpful? And I point to this article, which was actually just published just a couple of weeks ago, actually, where we review a lot of this information. And there are definitely some patient groups where reduction of EVP may be most helpful. So normal tension glaucoma patients are one. ILP is already low. And so when ILP is already low, reduction of aqueous humor production or improvement of uvoscleral outflow facility actually has a limited effect because you can't go below EVP, which is typically about 6 to 8 millimeters of mercury. Whereas if you reduce EVP, that gives a 1-to-1 reduction in ILP. Angle surgery is a group where this may be particularly helpful as well. So angle surgery already optimizes outflow facility. That gives you a larger denominator in this equation, and so reduction of Q or U has limited effect. And again, EVP and LP vary in a 1-to-1 ratio, so this may be particularly effective in these groups as adjunctive therapy. Same with SLT, really the same arguments there. And then patients who have very low pressures, target pressures in the low teens or less. And typically these are patients who you've already tried aqueous humor suppression through medications, you've already tried to improve the uveoscleral flow, again through prostaglandin or maybe through surgery or SLT or MIGS. And so that leaves EVP as the untreated target here in the modified Goldman equation. And in these patients, EVP is going to be 50% or more of their actual ILP, so it's an obvious place to try to target. And then finally, elevated ILP. So if you have a patient like this who has a severely dilated episcleral vessels from a carotid cavernous fistula, you're going to want to treat the underlying mechanism first, obviously. But after that's been done and you want to try to reduce episcleral venous pressure, then that is a reasonable target. Once we have medications that will target EVP as its primary mechanism. So to summarize, EVP is important. It can be measured objectively. It varies with body position and diurnal rhythms. Its regulation seems to be through dilation as well as through their arteriovenous anastomoses. Medications can affect EVP, and we're getting more medications that can better affect EVP. And then reduction of EVP is going to be most likely useful in patients who have low ILP, and its use will either be a standalone therapy or as adjunctive therapy. So thank you very much, and look forward to seeing everyone in Hawaii.
Thank you. Any questions? Yes, please. Aparna, can you come? Your talk is
Arthur, fascinating talk, great science. I have two questions. One is, does Rho kinase inhibitor have a different mechanism of action by which it is allowing the AV things to dilate but still lowering EVP?
Yeah, no, that's a great question because it's a vasodilator, and so the speculative answer, we don't have any definitive answer, is that different concentrations of drug may have different effects. So you may need a greater concentration to start dilating the AVAs as compared to the episcleral veins themselves.
I see. And thank you. And the second question is, when you measure EVP, which vein do you choose? Because there are,
Yep.
3 or 4 calibers. Which
Yep.
one do you choose?
Yeah, so we typically choose the ones that are easy to access. So that would mean superior or supratemporal. I mean, it's difficult to measure nasal just because the nose gets in the way. We can measure inferior, but it's a little bit less comfortable for the patient.
But do you go with the first vein that collapses, or do you go with the largest vein that collapses?
So we go with, so we typically target a vein that is nicely visible. And the balloon doesn't give uniform pressure, so we want to center over the vein. So if we have a peripheral vein off to the edge of the balloon that collapses sooner or later, it's probably not giving an accurate reading.
I see. Thank you.
any other? Yeah, Mike.
Fantastic stuff. In real life, we get a lot of red eyes from eye drops, including chronic prostaglandin use, with the argument that there is a chronic dilatation of those anastomotic vessels. And those of us in clinical trials work out that sometimes you take people off prostaglandins, their pressure goes down. Do you think that's the mechanism? Is that what's happening?
Yeah, I mean, it's interesting. I mean, it's certainly possible that there's some segment of the population that is more sensitive to Rho kinase inhibitors, and they're actually getting dilation of the AVAs. I actually think it's more just a matter of those eyes are so red and irritated. I mean, I'm sure you've seen patients who have medication allergies. If you take them off of the offending agents, their pressures go down. I think it's probably more that effect, but it's certainly possible that there are some patients who are more susceptible to a lower concentration of drug, and they are getting elevation of EVP.
is there a subset of patients that you would like to, test for their EVP, or do you do it in a routine practice?
Yeah, I wish I could do it routinely. It's not an easy procedure to perform. So right now we're only doing it for research purposes.
Thank you.
I have a question, sir. It's a very interesting talk. So you mainly said that EVP lowering may be effective in patients with normal tension glaucoma. Any conditions where you think where the EVP is elevated? For example, we are very interested in our patients with thyroid ophthalmopathy, which have long-standing ocular hypertension not resulting in glaucoma. So could there be role in such patients where EVP is high and we lower it?
Oh, no, absolutely. I mean, that's not a group that I've thought about, quite frankly, but I think it's certainly possible with the orbital congestion that you could have elevation of episcleral venous pressure just from putting pressure on the vessels there and causing a back pressure. So I think it'd be very interesting to measure those patients and see what the effect of EVP lowering treatment is.
Any scope of that balloon that you're using to be available commercially for use? So this is basically a research tool, I believe.
Yeah, it's a research tool. Again, it's not easy to use. The analysis, the video analysis is a little bit complicated.
Yes.
So we are just using it for research now. It'd be great if we could simplify it to a clinical tool, but certainly not there yet.
Yeah, thank you.
Thank
So we would like to introduce Dr. Aparna Rao. She'll be talking about minimally invasive trabeculectomy next.
Hi everyone. So this is a form of ab interno trabeculectomy, and this is a technique that most of us will be able to do because the technique is very similar to the external trabeculectomy that we do, only with the difference that you can do it from inside as you do for any mix. Now what is required is, unlike the other procedures, you don't need very sophisticated instruments. You just contact your retina colleagues, get the straight 25 gauge micro scissors and 25 gauge micro forceps. That's all that you need. And if you get not the disposable ones, if you get one investment like a stainless steel or titanium, that's all that you need apart from the lenses. Understand the procedure. This is an excisional procedure. This is not just incision. We excise the TM because that I feel is more important, because if we leave the TM there to fall back on the iris, you are anyway rendering it dysfunctional. So there's no point of keeping it there, because then it will go and reattach and then there may be problems. So excise the TM. Where is it required? Now, currently we are using it for a lot of indications, much similar to what we do a trabeculectomy otherwise, but yet we do not, unlike any mix, we are not doing it for very refractory glaucomas or NVGs or inflammatory glaucomas, because in those angle procedures you are still having your prohibitions and doubts that whether mix will help. So when you're sure that you can do a mix, that's where you can do an MIT also. And how do you do it? It's just practice, because if you're doing an MIGS, then you can do this. If you just practice, all it needs is understanding how the TM tissue feels, and then how exactly do you rip it so that it is completely atraumatic. So this was a journey that I started off familiarizing first with other procedures like GAT, and then which are equally effective, bang and syneculisis. Then I moved down to the other procedures before I understood how the tissue looks like, and then go to doing the excising the trap. The procedure, like I said, is very simple. If you see any strands, even in an open angle glaucoma, you can see some iris strands which are going and attaching forward. So with a cyclodialysis spatula, after you form the put the viscoelastic, just take a cyclodialysis and push the iris gently downward so that your angle is completely open. Now this is important because we excise the entire TM. Unlike the other procedures where you incise between the anterior and the posterior trabecular meshwork, we are incising at the level of the Schwalbe's line, so that you are removing the juxtacanalicular tissue also, and the corneoscleral meshwork. And the second incision is actually, the first incision will be at the level of the Schwalbe's line, and the second incision will be at the level of your iris root, just above the iris, so that you are able to excise the entire TM tissue. It comes off in a very single strip. once you have made 2 horizontal incisions, you make 2 vertical cuts with the straight micro scissors. And once you have delineated the TM tissue over 3 to 5 clock hours, you just hold with an ILM peeling forceps or end gripping forceps as they call it. Ask your vitreoretina colleagues, they'll be able to do that. Just grasp the TM piece that you have cut vertically and then just strip it off gently. It just comes off very easily. And unlike the other procedures where you are gouging and pushing an instrument beneath the TM, here you are not touching the trabecular meshwork save for only the ends which you have delineated by the cuts. You can do blanching or you can put trypan blue to evaluate whether your procedure is effective. And we did a study to find out whether this can be useful. We found that if you have more than 2 quadrants of blanching and trypan blue staining, you can be assured at least this patient will be controlled without medications or may not require too much medications. For us, this was like a boon because unlike the suture GAT which we were doing prior to this, there were a lot of cases, all of you might be aware that we have a lot of macro hyphemas with GAT, and for some of our patients this is really distressing. And remember, the hyphema does not happen just on POD1, it can happen even late, few months later also. If they have a Valsalva procedure, they may be bleeding into the anterior chamber. This is not very uncommon, rare but not uncommon. So with MIT, the hyphema is intraoperative bleeding is also very minimal, and POD1 you would not find almost in all the cases, only a trickle of blood, that's it. Otherwise the anterior chamber is completely clear, and this is because you are not forcefully ripping the trabecular meshwork. There is only a gentle stripping and you are not touching the TM or the collector channels beneath the tissue. The amount of pus that we see in the quadrants that we have dissected is very minimal. It's very focal that we see. The fibrotic closure, or what Dr. Vinay has described as a hypertrophic scar on AIOS is, again, the amount of scar that we see is very minimal. And because there is no sudden forces of stripping away, forceful ripping away of the TM, you don't see that gush of bleed that you would normally see with GAT when you're ripping off the TM in all the 360 degrees. Because we are excising the TM, the chances of reattachment are very less with this procedure. This is less traumatic, less hyphema. Whoever has done it has always reported one thing, that yes, POD1, the cornea is clear, the chamber is clear, and we don't leave any viscoelastic. If at all there is intraoperative, we find a trickle of blood, even at the end of the procedure, what we do is just leave an air bubble. So POD1, actually the visual acuity is very good, and they don't have any rebleeding even later. And the incidence of pus, like I said, is very less with this procedure. You can keep the patient on pilocarpine for 2 to 4 weeks. Some prefer to keep it for a longer time, but I prefer to withdraw them at 3 weeks to 4 weeks. And the pus is very less. Once 1 month is over, if you wean off the pilocarpine, the chances of pus are very less. So initially we started off to do it in primary open angle glaucomas, but this is also useful now with goniosynochialisis in angle closure. We have tried it in steroid-induced glaucomas, angle PAC eyes, ocular hypertension eyes who are not otherwise tolerant to medications, and even exfoliation glaucoma. Like all the MIGs in exfoliation glaucoma eyes, this procedure works really well, with most of them being off the medications at even at 1 to 2 years. JOAG, like other MIGs, we have our reservations because the predictability is somewhat different, because some eyes perform very well, while the very advanced JOAGs, some of them the IOP spikes may happen. And even patients who are allergic to drops, or you can combine this with phacoemulsification, or even vitreoretinal surgeries where you want angle control, IOP control, you can do this procedure because it's atraumatic. And angle recession, again, is one of the reservations that I have. It does not perform well like any other GAT or other procedures. The advanced JOAGs and angle recessions, you do this with caution and assess the patient. Offer that only if you're sure that your mixed procedure, angle surgery, is going to work in that patient. So there are expanding indications that this procedure can be used. Thank you.
Any questions from the audience?
I would request the delegates to please spread out because there are others who are not able to view the screen. So maybe on
So
this
you've
side.
also done
Can we get
histopathology
more
of
chairs?
that trabecular
Yeah,
meshwork
so
of Arnav.
I did not include here. So the incentive for me to get the trabecular meshwork was not actually clinical. The moment I could understand that the trabecular meshwork is out, the incentive for me was to put it down to downstream analysis for basic research, because all of us glaucoma surgeons remember that the trabecular meshwork that we get externally has cornea, sclera, and the TM in the sample is a small part at one corner, and many of the samples may not even have the TM at all. What you have removed is a corneoscleral block. So this was a pain for us when I was doing my PhD on molecular biology in glaucoma. We were not able to do any basic research on the trabecular meshwork. So when we got these samples, now when we analyze the histopathology and put it down to other analysis like single cell or transcriptomics, this tissue, you will be amazed at, you can see all the three layers, namely your juxtacanalicular, your corneoscleral, and sometimes the uveal meshwork intact with a lot of cells, which is almost very rare in your external trap specimens. So this I am using it for basic research applications. I'm sure all of you can also do that. Yes. Angle recessions, yeah. Yeah, so I have done, why I said I'm doing it with the reservations, because when you do the procedure, if you have touched the TM, which is naive, meaning that you have not put any suture or any instrument beneath the TM, that tissue, when you strip it and take it off, put it on a filter paper, it will be, I describe to everyone knows how sushi, the fish skin looks like, a thin layer. The TM feels just like that, a shiny, glistening layer. Across, you may say 4 to 5 millimeters, right? When you flatten it on a filter paper. But in angle recessions, when you try to grip the trabecular meshwork with your ILM forceps, you would find that, you have a very sandpaper or a gritty sensation. You can just feel that. And when you strip that, you can see that all over it has a very gritty sensation. It does not strip very easily. So there's a lot of fibrosis. So when that has actually happened, at least my take is that it's not just the trabecular meshwork, the distal pathways distal to the trabecular meshwork are also fibrous. So only taking the trabecular meshwork or doing any angle surgery may not be sufficient in that patient. So when I find any abnormal, like Dr. Vinay has described, abnormal iris processes at the angle dysgenesis as we call it. So when you see that, or in case of angle recession, we are able to see a lot of pigments and abnormal iris, there I don't prefer to do an angle surgery, not just MIT, not any angle surgery, because there I know that it's not just the TM, it's the distal pathway as well.
Ma'am, that was a beautiful surgery. I
Thank
just wanted to ask a question. When we do angle surgery and try to peel off the trabecular meshwork, it's very easy because it's porous and it's easy to peel. So, but when we take the incision from the Schwalbe's line to the base of the iris, it will include the area of the scleral spur and the area in front of the trabecular
The
meshwork.
scleral spur will not get included because it detaches from that.
Okay.
So when you strip it, the detachment is not very traumatic, it strips. That's why I said the second by experience, I've had experiences, if you try to strip it, if you have not cut the inferior horizontal incision, if you have not made, some of the iris strands that are attaching there, that will not allow your stripping to happen. So with a cyclodialysis spatula, I always try to cut those iris strands and I make an incision not only at the Schwalbe's line, but a very superficial incision with a MVR blade at the level of that, just above the scleral spur, so that tissue can be
And you
taken
don't
out.
encounter any cyclodialysis clefts
No,
with this?
no, never, because you're not going deep. Never go deep, because you remember, you have to visualize that, yes, when you're making an incision with your MVR blade or anything, you may encounter your ciliary processes behind the iris, so always be careful. So like I said, the second incision has to be more superficial as opposed to your first one. You have to be cognizant of the fact that the ciliary process may be behind.
Okay, thank you so much, Aparna. We'll have our next talk, which is something very interesting, the bimatoprost implant, which Michael Coote from Melbourne is going to tell us about.
It's amazing to have standing room only in a in a glaucoma session. Do you want to have a moment, see if you can find another seat or move? Are you okay over there? All right, we shall continue then. Sorry, I'll go back on that. Yes, that's right.
Yeah, do you want to come in
Anybody who
front?
wants to come and sit in the front?
Front?
So, or maybe on the aisles? Yeah.
We can't turn away people from a glaucoma session. That's something wrong with that.
Yeah, you can please come.
The youngsters can come in the front, please.
That's right. Maybe if the speakers come up.
Alex,
Why don't
Alex,
why don't you bring the speakers
Dr.
up?
Professor Arthur,
Come
please.
in.
Please. Yeah. Yes.
I feel like I've derailed your session now, Vinny. I'm sorry about that.
Yes.
It's a good problem to have, though, isn't it?
Yeah, Vinesh, you said that we need a bigger room.
Yeah. It's because of Alex. It's not, that's right. So we're talking a lot about drugs and new drugs, but old drugs delivered differently matter as well. And this is in line with essentially all of medicine. The idea of targeting a medicine to exactly the space that it's needed, that is one way of preventing side effects. So one of the things that we know, of course, is that drops are a very inefficient way of delivering medicine to the anterior chamber. In fact, I've been in practice 30 years and it still surprises me that drops ever get into the front of the eye at all, but obviously they do. But we deliver a large amount more than is needed. A lot of people don't administer them very well. Many people, in fact, even miss the eye when they're observed. A lot of the bottles are contaminated. There's all sorts of different problems with them. We all know these. There's also a poor adherence rate. Some of this is from US data where there's almost a disincentive, and where in Australia we're probably a little bit better, but in fact this is fairly common over the whole world. There is quite a significant reduction in how many medicines are taken over time. And unfortunately that does have a corollary to the effect of treatment. So if you look at people progressing, the number of medicines that are missed is definitely related to that. One of the most common starting medicines is prostaglandin, and of course a lot of prostaglandins produce conjunctival hyperemia. We're listening to a fantastic talk by Arthur, and I'm wondering really whether or not the hyperemia ends up being partly defeating of their effect. But it also produces orbital effects and lid effects, and they seem to have perhaps a genetic predisposition, but having said that, it can be very pronounced in a lot of people. So the idea of using perhaps a sustained release agent inside the eye has been an attraction for some time, and there are now 3 of these that are in advanced stage or commercially available at least someplace in the world. Just to note though, that in dogs using some data from AbbVie, there is a large amount of prostaglandin that goes into the orbit and goes into lids, and if you biopsy the tissue around an eye, you found really quite significant doses, in fact significantly higher doses than's in the eye, which is a bit disappointing. Of course, you can tell the eye that's having the prostaglandin in this picture, and it becomes quite noticeable when it's put in one eye. So there are 3 front runners in this space. One of them is AbbVie's Bimatoprost SR, which is a so-called Durista. There's a polyactiva product, which is from Australia, and I'll talk to you a little bit about that. And then there's the Glaucos iDose TR. They're all effectively prostaglandin release. There's a little movie from AbbVie. It's actually not unlike that when you do it. It's a relatively straightforward process. It sits in the inferior angle. It is a opaque, white, small object which is quite visible and sometimes is adherent to the iris before it makes it to the angle. It's designed to last for about 4 months, or at least 4 months. It's actually a little bit difficult to know sometimes when it does stop working because the implant is still visible even after it seems to have lost. It has 10 micrograms in a basically bioerodible kind of container. But, you know, the sobering component of this is that in one of these agents, there is only the amount of medicine that is in one drop of drop that you put in it lasts 4 months. So the amount of overkill we're having with topical medication is quite extraordinary. That's the size of it, which is very small. Now, I've used quite a few of these in a study, and they do work. They're nice. They when they're piled on top of each other, so if you use more than one, you do run an increasing risk of accumulation of prostaglandin locally, and there is some inflammatory sequelae from that, and there has been some endothelial changes which are mostly reversible. Over a period of time, they become that kind of honeycomb structure on the right-hand side of your screen, and then there's probably no drug left in them. That's essentially the process of change over time. They swell to start with and then shrink, but you can usually see them even many years afterwards. The polyactiva uses a very different chemistry. The chemistry is really quite interesting, and in fact a very clever chemist worked this out, that you can stitch things together using these biodegradation components that allow you to slow or speed up the rate of degradation. And again, really small amounts of drug are needed, but you can structure this, and now you can put them into this now completely clear structure, which is implanted in a very similar way. In fact, the video for the Durista would be pretty much the same. It's very hard to see. It can be a bit frustrating. I was just talking to Sanjay before. It can be a little bit frustrating when you put them in because you can't actually see them, and they're not visible on ACT, but they do disintegrate completely, and there's no residue. There's not been the inflammatory components, potentially probably because it's a slightly larger size, and the material that is the sort of degrading components of it don't seem to be inflammatory. They work well. This data would be pretty much the same as Durista. You're getting good long-term use. They're building currently one that will work for a year, and there's good reason to believe it will work for a year. So you'll be able to give a single injection into the eye, which will last a year. This technology is remarkably stable, and when we were doing some of the preliminary studies, they said that it would degrade in 26 weeks, and you think, well, that's kind of a little bit of nonsense, but it actually degrades in 24 to 27 weeks in everyone, so it's quite an extraordinary technology. A lot of good data, but again, very similar to all the others that are around. Finally, of course, there is the Glaucos AIOS TR, which is a kind of very different device, and I'll show you the video of that. This is courtesy of Glaucos, but it's certainly much more an operative intervention. This can't be done in the office. The others can be done in the office. And it has this proprietary release system and a form of travoprost, which is not used as a drop. It's in an oil form with a membrane. Now, those of you who've used eye stents, it's obviously a very similar process to that. There is a bit of bleeding, and presumably you could get a little bit more on occasion as well. The results are encouraging, there's no doubt about that. This is probably a more sophisticated release system. The intent is that this will last up to 3 years, so it's quite now a sustained release, but over a long period of time. I think there are challenges, I think, to get the predictability over that length of time. So certainly at 2 years, you're seeing it. They are measuring intra-chamber concentrations of travoprost and the free acid, which is the active component of it, and there are good endpoints up to 24 months, so it's quite encouraging in that regard. Having said all of that, there are a lot of controversies about all this, and the first one, of course, is just the value of it. These are expensive products, often far in excess of that which would be in the domain of the drops, even if they were the latest and greatest drops. There's no doubt that if you got increased compliance, if you got all of the things that are puted as value for someone who was unable to use drops before and was the alternate, was an operation, then it would have cost effectiveness. But I think if you were saying just to do this for someone who was reasonably efficient at using drops, I think the cost effectiveness would be a challenge to make. There is some safety issues, anything that stays in your eye for a length of time, and so the complete absorption of the latter, the polyactiva device, is a kind of reassurance. The non-absorption of the bimatoprost completely is a tricky one because you can't quite tell whether it's still releasing drug, and we've got no long-term issues associated with the metal insert part of the eye dose, but one assumes that could possibly give issues. There is endothelial loss that's occurred because of multiple doses of Durista, usually focal, but it's an inflammatory process almost certainly. The length of efficacy, of course, one of the whole things about this is that you could give this to someone, they could go away and then not come back. But if there was some variation in the length of efficacy, that would be a big issue. So you would not be able to determine that easily. And so once you're getting out to things like 2 years, if there was significant variation after that, you may end up giving reassurance to patients, which was not appropriate. So the variability of effect as well is something we've seen people in whom we put these in and haven't had a terrific effect, and other people where it's been very profound. And then there's a prolonged effect afterwards, which has been called pharmacosurgery. So the idea that you get this continued effect even after the prostaglandin is gone. I can see Alex moving his head up and down, but whether that exists or not, I'm unclear. So perhaps Alex, you can comment on that later.
Sure.
And then there may be this conversation that we're also having about the decrease in episcleral venous pressure, which is really just about the side effect of the prostaglandins on the surface. And this is a Mike Robinson view. I'm not sure whether or not it's supported by anyone else. Of course, this person was in a trial, and you could see that after 6 months, you can quite see the eye that was in fact treated. So you don't get prostaglandin side effects into the orbit. So it's quite a profound effect. The future is bright. Thank you.
Any questions? You can,
Yes.
the mic is
All right,
here.
right there.
A lovely talk, sir, Dr. Coote. My questions are a few. These can be implanted even in a narrow angle glaucoma, in the angle?
Yes,
have
they're
you done
not
that?
currently meant to be, any of them.
Yeah.
We have put them in reasonably narrow people.
Okay.
And somewhat, just because of set of circumstances, we have had one that actually touched the endothelium until it absorbed, and it didn't cause any particular issues.
Okay.
It's still a matter of a little bit of controversy. There's no doubt the people at AbbVie think that the contact is a problem. I have to say my personal view is that I don't think it's that. I think it's a toxicity issue if you get it. So, yes, you can, but they're a bit more designed with this space. Yeah.
Okay. What is the post-op regimen that you use when you put in the implant?
Well,
And for how many days? Are you using topical steroids to prevent inflammation? Or are you
No.
using topical antibiotics because
No.
it's an intraocular procedure?
Well, no to both of those. I
No to-
might get some pushback from the audience. We do it the same as you would do an intravitreal injection, which is that topical antibiotics afterwards, prophylactic, are a bit of a problem. The microbiologists don't
But
really
no
agree with that.
low potency steroids required, no inflammation seen.
No, you don't get any inflammation really. You don't touch anything, so it goes through clear cornea.
Okay.
Yeah.
And you're not filling the chamber with a viscoelastic, you're just going and injecting.
Well, it depends on which one. The iodose does.
The first
require
one?
that. Yeah, both of the first two.
Yeah.
No, they're just done in the chair, in
Okay.
the office.
And it dissolves after 3 months, or it remains there and you put in another pellet?
The
Where
latter
when you have
one.
to reintroduce, have you reintroduced also?
Yes,
in a
we've
second?
done in both of those
So
ones on the trial
does the
basis.
pellet remain inside or it dissolves?
The Durista remains visible, but
Okay.
it probably has no drug left in it, whereas the latter, the second one, remains completely, it goes entirely.
And post-op, do you ask the patient to be propped up for a day or two so that it settles in the lower angle, or with the
No.
movement of the
No.
patient, does it move to the angles and to
It
the
does
sides?
that, you aim it towards the inferior angle, and it generally lands there pretty quickly.
And it sticks there? How does it
Yeah, they're both
remain
mildly
there?
adherent to iris, so they tend to stick to iris. They're intended to do so.
And the adhesion comes after how many days?
Well, it
Like,
probably comes after
suppose the
hours.
patient wants to sleep on his tummy or has a habit, do you give some kind of
Well-
post-op instructions?
These are all very good questions. In a trial, we wanted to be able to see it, so we did give those instructions. But in real life, it wouldn't matter. You could put it behind the iris, so you don't have to observe it. So I think it was only in the trial circumstance where we gave that
And
instruction.
in the last implant, the last question, in the last implant in the IDOS, which you're saying is effective for about 3 years, then
That's the intent,
when you
yeah.
put in another implant, would you like to take out the other one?
I don't know they've got to that point yet. So,
Okay.
yeah.
And the intra-bleeding that you had, would it obstruct the mechanism of diffusion of that by fibrosis?
I do confess that's not my video,
Okay.
so I'm not sure about it, but it could be an issue, sure.
Thank you.
Yeah. Alex.
I can make a couple comments to your questions. I've done both clinically and not in studies. iDose is a surgery, so you're giving antibiotics, you're viscoelastic in the eye, all that kind of stuff. The Durista stuff is not surgery. I also treat it like an intravitreal injection. And you ask the patient to make sure that they're upright for the rest of the day. So they don't need to it's not like a very, very long time. The pharmacosurgery thing is interesting. So I like mysteries. When I have my talk, it's about mysteries. I like mysteries. So the mystery is this. As Michael was saying, on the AbbVie side with Durista, it's very clear that the drug is gone in 3 months. Glaukos is also saying, because they're measuring drug, that the drug is gone in a couple years. Clinically, I've done both. I don't have 3-year experience, but I have with Durista 1-year experience where the effect lasts for almost a year, but it's slowly going away. And Glaukos is saying the same thing, that after 2 years, the effect is dragging on. So when clearly there's no more medicine left. So there is some kind of modeling long-term change to the eye, which could be beneficial. And that's a mystery that I think needs to be explored.
Any questions?
Supposing the patient is like sleeping is a different thing. Beautiful talk, by the way. The sleeping is a different thing, but the patient is walking or maybe running to catch a train or something. With the eye movements, would these implants move?
I may end up disagreeing with Ali. I don't think it matters where it lands in the eye. For study purposes, it's nice to be able to see it. But I think Mike Robbins and I were talking about putting it actually behind the iris.
Yes.
So in phakic eyes, it doesn't cause cataract?
No. They're tiny things. They're almost isodense. They do fall with gravity, but only just. It's just nice to be able to see it, that's all. If you want to see it, you put it in front of them.
Great, thanks for a very nice talk. My question is this currently approved for use in Australia, and how much does it cost there? I ask.
No, it's
Okay.
not approved for use.
Yeah, I ask because in the United States, it's approved. The device alone costs somewhere between $10,000 to $14,000, which sets some sort of record for at least cost-effective treatment.
You mean iDose, not Durista?
iDose,
Yes.
that's correct, iDose.
No, Durista is much cheaper than that.
Right. And so I bring this up because obviously we're in a country where glaucoma care is much more cost-effective. But this is a major concern, and it'd be interesting to see in a different country how they determine the value of this device.
I think if you, the short answer is it wouldn't get across the line.
One last question if we have time. I was interested, with all the intraocular implants, drug delivery platforms, what happens if the aqueous composition is not, ideal? Let's say if you have uveitic glaucomas, or if you have some kind of plasmoid aqueous, or the aqueous composition and the function is not normal. So how does the pharmacokinetics of that implant change? And how does that impact the intraocular?
It's a great question. The inventor did do a little bit of that, but only ex vivo. The answer is it doesn't seem to matter. The level of protein, at least for the latter, doesn't alter it. It's essentially an aqueous process, and as long as it's still 95% water, it doesn't seem to make a difference. It does matter on temperature, though, but I don't think your anterior chamber varies enough for that. But I think if you got down to very low levels.
Thanks, Michael.
Thank you.
Thank you for the exhaustive discussion as well, along with the beautiful talk. Now we next invite Dr. Alex Huang, who will be talking about uveitic glaucoma surgery. It is back, the pearls and the mysteries.
Okay, thanks everyone for being here. Uveoscleral surgery is back, at least in the United States, what I'm referring to. We'll talk about pearls and mysteries, because I told you I like mysteries, and so there's mysteries here. Here are my financial disclosures. I actually have no disclosures for this particular talk, and my sources of research support as well. So I like to start with a little bit history first, right? What were the original observations that led you to think that there was even outflow? So this is, Lauber's dogs in the 1900s, where Lauber took the episcleral blood around the eye, and then he took the episcleral blood around the periphery of the dog. And what they found was that the hematocrit was lower in the blood around the eye, and that led to the idea that the eyeball was letting out a clear liquid to dilute the blood, so therefore, trabecular outflow, one of the first observations. What about uveoscleral outflow? So this is 1950s Anders Bill. So he would put in radioactivity into the eye and then collect the radioactivity out of the eye from the trabecular pathway. And he realized that every time he could never really get back what he put in. So there has to be a second door, and the door was big. So what he then ended up doing was sacrificing the animal, putting a piece of film on the tissue. The radioactivity would develop the film, and that's called autoradiography. And guess where he found the tracer? In the uvea and the sclera. Hence, uveoscleral outflow was a second door. The lost fraction. So why does this all matter? Well, thank you, Arthur, for setting this up already for all of us, at least with respect to trabecular MIGS. Once you put the Goldman equation up there, the idea is to make resistance zero, although you know we probably don't even really achieve that, but that is the goal, to lower the pressure. But as Arthur had mentioned, there are limits here for trabecular surgery because you're only going to get as low as EVP. While it's pretty good, you know, we don't even quite get there. There's limits. From the uveoscleral side, then we have the modified Goldman equation, where your original F variable for, you know, aqueous flow rate gets broken up into two pieces, including F out, which is uveoscleral outflow. Now, the thing to point out here is that F out has a negative symbol in front of it. So if you make that a really big number, it's a really big negative number, which can overcome all the other variables in the equation, and you can get a really low IOP, which you know from traumatic cyclodialysis clefts. That's why there's a lot of promise here. So let's remind ourselves a little bit about the pathways, because clearly uveoscleral outflow is not taught as well, right? At least it's in the name, it's in the UV, it's in the sclera. Okay, we start in the anterior chamber. It's going through the ciliary body band on gonioscopy, so you actually are looking at the door. Then you have the ciliary body cleft, which is the key piece, right? Because we're very clear that trabecular meshwork is the key piece for trabecular outflow. So what is the key piece for uveoscleral outflow? It's the ciliary body cleft, going to the suprachoroidal space, and then there are multiple parallel pathways. So in the red arrow on the right, that's trabecular, number one. Number two, uveoscleral is the green arrow. That's where it starts. And the black arrows are pointing at the clefts. Let's talk about this a little bit more. So these clefts were noted for a long time, typically on histology 25 years ago here, right? These clefts, some people debated, were they artifacts of the histology or are they real? And so the idea is that these could be real because, as we know, when people get older and animals get older, uveoscleral outflow goes down. And then if the same sectioning is performed in an older animal or person, the clefts go away. So this is kind of circumstantial, but the idea is that the clefts are very important to uveoscleral outflow and something we need to maintain. So how can I prove it to you? I can punch you in the face because I can give you a cleft. It's the same cleft. Ciliary body cleft here. Over here, it's called cyclodialysis cleft, right? It's an iatrogenic creation of the actual same thing. And you guys know pressure can be really, really, really low. The problem, of course, is I can't quite punch you the same way every time in every patient. It's so stereotyped. So we want a surgery to do that. And this is why there was the whole field of, uveoscleral MIGS coming along. There was the Solex Gold shunt on the left. It failed. It got too scarred up. Glauco started developing the iStent Supra, and then they stopped developing it, and nobody knows what happened. And then we have the CyPass on the right, which some of you may be familiar with. The CyPass was FDA approved in 2016 for lowering pressure. It's this implant that's stuck into the suprachoroidal space to create that cleft. IOP did drop. Patients got off their medicines a little bit, but okay, mystery number one. It's not that strong. It's like trabecular MIGS. I thought we were supposed to be dealing with hypotony here. Kind of weird. But we never really had the time to figure it out. Why? Because then it wasn't safe and the cornea was dying, and so then the product was pulled from the market. And I thought at this point that nothing would ever happen and, the whole space became radioactive. But at least there were still, industry members that continue to push this space. So I give iStar a lot of credit as they continue to develop MiniJect. MiniJect is not available in the US, so I've never done it, but is available in other places in the world. It's another implant that can go into that space similar to CyPass, supposed to be safer. But yet again, if you look at the right, pressure's not that low. Yet, maybe in this surgeries, it should be lower. From my experience, the only thing that we have available right now is the AlloFlow. So this is an implant, but it's just a piece of sclera, just like the sclera that you put on the glaucoma tube, okay? The idea is that it's acting as a spacer and it's porous, so it can let fluid through. The surgery kind of looks like this. You have a spatula, you create a cyclodialysis cleft. Oh my gosh, it looks so scary the first time, but it's actually, pretty easy to make. And then you put the sclera in there, either one piece or two piece with a gap in between. And that seems pretty scary as well. What do the results look like? These are all results with only one single scleral piece. And it looks like MIGS data, trabecular MIGS, meaning mid-teens IOP, and you get off a drop or so. So again, we're back into that space. And why isn't this more powerful and simultaneously maybe a little more scary? These are just my experience. I only started doing this surgery for the last couple of months. This is an Asian man who came from New York, multiple surgeries, high pressures. He got cataract surgery, the pressure jumped, and so he didn't want the second eye done. Eventually, his vision was decreased, so we did the second eye cataract surgery, and I said, okay, why don't we do an alpha at the same time? At least maybe your pressure won't jump. Pressure's doing okay. We got him off one drop. You know, it's not a huge decline, but he wasn't that high to start with. I will say that, you know, I did my first double piece surgery just a couple of weeks ago. You can see the 2 green arrows. If I put the slit beam on it, it turns to white. But you can see the little gap in the middle. At post-op week 1, this person's pressure is 5. I've heard from my fellows it's starting to move upward. So it is thought that, you know, 2 pieces can be stronger. So then let's start talking about the mysteries then. We've already been hinting at it. Why are these surgeries not stronger and simultaneously more dangerous? We all know that a traumatic cleft can give you a really, really, really low number. Well, it may be that the outflow in the uveoscleral space is segmental. Many of you may have heard of me talking about this story for conventional outflow. This is now only being studied more recently. This is Haiyan Gong's work from Boston. It is animal data, putting these microbeads in the eye, showing that at least for uveoscleral outflow, it's more on the bottom of the eye. So it may be that, you know, depending on where you put the surgery, you may have a bigger effect all the way to hypotony. And since we're always placing it nasal, maybe that's part of the issue. Mystery number 2, and this is the one that's very interesting. Do you even need to be connected to the anterior chamber for this to work? So there are a couple of stories out there of CyPasses that were badly placed. They were placed so deep that the cleft was closed, yet IOP is still low. Really? I don't know. But then there's Ciliatech that's coming in Europe. Ciliatech is an implant that just goes into the suprachoroidal space ab externo. They claim no connection to the anterior chamber, and they claim it works. How? There's also on the bottom the hydrogel injection. This is from a friend of mine, Ross Ethier in Georgia. I trust Ross a lot. This is monkey data where he injects a hydrogel externally and creates an expanded suprachoroidal space. And Ross also says no connection to the anterior chamber, but pressure is down. Kind of weird, but it does remind us of the original data that the most important anatomical piece of uveoscleral outflow is the ciliary body cleft. However we make it, maybe it doesn't need to be connected. So in conclusion, uveoscleral MIGs are back. At least in the United States, we have Alaflow. Mini-inject has been around for a little while outside of the US. These surgeries are safe and effective, but it's kind of weird. Number 1, there's clearly IOP reduction left unachieved. Surgeries should be stronger, they should be riskier. There is something we don't understand, and so there's room to improve here, and I'm kind of glad we have the chance to study this now, unlike CyPass. And then number 4, is a connection to the anterior chamber even required? Somehow there are devices and thoughts out there that that's not necessary, and this is something we need to figure out as well. But overall, I think the good news is that we actually have tools again to be used in our patients that then we can use to try to figure out some of these mysteries, because due to the modified Goldman equation, if this really works in terms of attacking the ciliary the uveoscleral outflow pathway, we could actually achieve very low pressures.
Thank you, Alex. Any questions? I think that was very interesting.
I was going to say Sanjay was the only one who's not allowed to ask questions.
So I have first of all, fabulous talk, and I have been there. We've done cyclodialysis, clefts, and all that stuff. But I'm wondering if the latter half of what you discussed, where there is no connection to the anterior chamber, could there be a possible mechanism by which the ciliary body actually is not producing enough aqueous to lower the pressure, rather than the outflow?
Totally. So what you're referring to is that, you know, we have cases where we have, you know, these shallow choroidals and the ciliary body's detached, and if the ciliary body's detached, it's not producing aqueous well, so therefore maybe IOP's down like an aqueous suppressant. A couple of responses. Number 1, they're small devices. Really? Just a couple of clock hours is enough? Okay, but maybe it is. Why? Because we typically say that, you know, production is pretty stable. So even if you knocked out 20% in one corner, like 2 clock hours, it's like, you know, 1 drop. So the possibility exists. So I expected someone to ask that question. And so I was going to be like, what are you going to do about it with it, Arthur? There's only a couple places in the world that can actually do the experiment to actually figure it out. Is it uveoscleral or is it decreased production? So, I mean, Celia Tech's got to come to you guys. Or Ross.
So, so there we go. Okay, so fantastic talk, Alex. Really interesting. I haven't done anything uveal sclerosis since IPAS, but I think one of the things that you've highlighted is the Goldman equation actually breaks down
Fair enough.
in these situations because you can't have true pressure-independent flow that is greater than the aqueous humor production. So the worst you can have is that first term being 0. You're still not going to be below EVP.
Makes it 0.
So you shouldn't have hypotony. So when you have a cyclodialysis cleft, a traumatic cyclodialysis cleft, and you start to get those hypotony and maculopathy, you're probably developing another mechanism, another outflow pathway that is not pressure independent, and that allows you to get below EVP. So it's essentially like an internal trab.
Yeah, I mean, you're saying the equation falls apart, and I agree with you, but still the hypotony's there. So the controlled surgery should be able to mimic the trauma. Unless the other idea is that are there a lot of people walking around with traumatic cyclodialysis cleft that really don't have low IOP, that we never diagnose because we never see? Maybe traumatic cyclodialysis clefts aren't that dangerous either.
So the other question to his continuation to what he's asking is like, since the equation itself falls off, now whenever we do a MIGS also, we don't know what happens to the distal collector channels and that over time. Does the body adapt to that reduction in the pressure by decreased production, or is there fibrosis of the collector channels or even fibrosis or scarring somewhere else? And that, because the equation is now completely gone, so is there something that happens in the rest of the quadrants that kind of defeats this purpose?
Well, I wouldn't say that the equation is completely gone. It's clearly just not explaining the whole thing, right? Because the thing is, you can still measure aqueous production in the setting of the surgery and get some insight there. And so, you know, as Sanjay suggested, I mean, I think that's a good thing to do. It may help provide or inform what's going on. So, but ultimately, that experiment's got to get done. And there's actually very few people in the world, and I'm not one of them, who can do those experiments.
We were
Dr.
also
Wang,
wa-
one
yeah.
question.
Yeah.
Yeah.
bit-
So,
Yeah, same thing as your tubes for the scleropatch graft.
Dr. Wang, my question is that creation of cyclodialysis cleft, you know, so cyclodialysis cleft per se cause a lot of hypotony. So now we are seeing a lot of MIGS being done, and a couple of patients have been referred to us wherein because of post-MIGS, hypotony has developed, and on looking at the angle after, you know, doing a good evaluation, the cyclodialysis clefts have been, you know, maybe 0.5 to 1 mm. Still, that is causing a lot of hypotony. So how sure are we that these, whatever instants are coming, that they will not have, you know?
Well, that's the mystery. I have done trabecular MIGS and inadvertently caused a cyclodialysis cleft that's tiny, and the pressure is crazy low. I've seen patients with trauma, and the pressure is crazy low. But you do all these surgeries, it's not crazy low. So that's the mystery. Even when I do the surgery, it's not crazy low. And so that's where there's something that has yet
So
to be
like,
understood.
do we have a long-term data for it? Like how long?
Well,
what's
CyPass as
the-
well as, I mean, forget about Alaflow, but you had CyPass. They didn't have massive hypotony in years and years of studies with many, many surgeries performed. I mean, did you even have any? No, 0, yeah. It doesn't make sense. But there's also potential.
Alex, how much of the sclera is in the intracameral space, is in the
Oh, it's just
angle?
it's a little tip. The whole thing, I think it's 6 millimeters long. You
Yeah.
make the cleft, you put the visco cannula, you push, and inside your imagination is like, oh my gosh, there's a big hole. You shove it in there, and then you're just trying to tip it, so just a little bit is sticking out.
Like 1 millimeter or so?
Or 0. I mean,
So
I'm
and
pretty
the-
aggressive.
I believe the cyclopen is different from the spatula that you're putting the graft with. So how do you titrate your cyclodialysis cleft? Because
Oh, yeah,
because
yeah.
there's
So
no
you make a
titration.
couple of clock hours with your spatula. It's like you're
And
making
how
a
deep?
cleft.
How deep are you
Oh,
going?
not deep at all. And then what happens is you stick the visco cannula into the hole and you push, and then that should make everything in your imagination it's bigger, right? And then you stick the whole thing in.
Michael has a question.
Alex, can you tell me, and I'm sorry to ask a completely different question, where is the fluid actually going?
You mean in uveoscleral outflow?
Because
Okay.
in animal models, I get it, but humans, it seems a lot of it is transretinal. It's sort of sticking in your retina.
I mean, after you get to the suprachoroidal space, of course, then we're starting to invoke many models and many species, but there are many multiple pathways that people have described through the vortex veins, through the actual sclera itself, through maybe uveal lymphatics that are regionally located. And a lot of this data, I take it, you're right, comes from different species, right? And so if you were to say to me, can you tell me exactly what's happening in a person, it's a little harder because some of these experiments were invasive.
So I would like to add to it. We did a ICG angiography in one of the eyes with traumatic cyclodialysis with really low IOP before correcting the cyclodialysis, and we found a lot of lymphatics there. So I believe for these surgeries also, the IOP should go down with time as lymphatics develop. So that could be one of the main mechanisms for the uvascular outflow to take place.
Arthur, do you have anything to add to that?
Yeah, it's a great question, and I think the bottom line is we don't know exactly the pathway of uveoscleral flow, even 70 years after Anders Bill started looking at it. But there is data that shows that it goes through the sclera, and prostaglandins change scleral hydraulic conductivity, and that's one of the theories of why it actually helps to lower IOP.
That would be a surface area. So the larger the surface area you have, because sclera is relatively impermeable.
Right.
Unless you think that uveoscular outflow is segmental, according to some people, meaning there's some segmental biology going on.
Yes, but it's still an impermeable structure. That's why we have
It's not impermeable. It's not impermeable.
Yeah, so it's,
but it is relatively.
Really low impermeable. Yeah, it's not very impermeable. Yeah.
but it's remember, it's not a high fluid flow that we're dealing with either. It's so.
But it keeps your eye formed.
Yes.
There's something wrong with that argument because otherwise the whole eye is porous.
Right, but
I don't understand.
So in terms of prostaglandins, one of the suggested mechanisms is that you can change the hydraulic conductivity of the sclera to lower it, so you actually get oozing through the sclera. But then where it goes after that is a little bit of a mystery.
It's subconch space, subconch lymphatics.
And then there's the work of Elkeluch and Dracol
Yep.
showing that if you give the monkeys prostaglandins for a long period of time, you get
Cis. Or clefts.
endothelialized channels in the ciliary body, and that may be pathways for aqueous humor drainage.
Another question, Alex. Were there any cases of chronic hypotony? Like how many cases of
I mean,
not even
if you look at all the CyPass cases, we'd have to go back and look at the study, but we're talking about, CyPass was around for years, right? Your chronic hypotony is going to be like this. And for the AlloFlow cases, it's much newer, so there doesn't as much data and as much time, and it's also like this, So again, that's the mystery. I mean, at the same time, first of all, I think someone used to say, if we're glaucoma specialists, we shouldn't be scared of low pressure, right? So we should have some lower numbers to maybe push a little scariness, and then we end up with something good, but it's not even quite achieving that yet.
Thank you. Thank you so much. We have our next speaker, and Professor Ki-Ho Park from Korea is going to talk about something very interesting, which is myopia and glaucoma. He has a very large follow-up of myopic patients, and this is something which is really a dilemma for a lot of us in India also. Thank you.
It's my great honor to be invited. These are my financial disclosures. So globally, the prevalence of myopia is increasing dramatically. In 2050, about 50% of the world population will be myopic, and 10% of the population will be highly myopic. And especially in East Asia and Southeast Asia, the prevalence increases more dramatically. So glaucoma diagnosis and monitoring in myopia is challenging because it is difficult to distinguish glaucomatous changes versus myopic changes. And in myopic eye, this could tilt with temporal stretching, peripapillary atrophy, and chorioretinal atrophy make it difficult to diagnose glaucoma. And in myopic eye, there is glaucoma-like visual field defect. So where are we looking for the structural diagnosis of glaucoma? We are looking at the optic nerve and peripapillary area, and also we look at the retinal nerve fiber layer with photography or with OCT. And also we are looking at the macular region to look at the ganglion cell layer change. And also we can take wider image of OCT, including both peripapillary and macular area together. To diagnose glaucoma, this hemorrhage is a kind of very nice clue. If we compare POH eyes in myopic disc hemorrhage and non-myopic disc hemorrhage, there is a significant difference. In myopic disc hemorrhage, it is most frequent in the lamina cribrosa area. In contrast, in non-myopic disc hemorrhage, they are least frequent in lamina cribrosa area. In this case, recurrent disc hemorrhage in lamina cribrosa area, B and C, you can find it. And after absorption of the disc hemorrhage, you can find lamina cribrosa change in that region. And also, visual field progressed in that region. Retinal null fiber layer photography can help us to diagnose glaucoma. So in this case, you can find superior temporal and inferior temporal defect, so we can diagnose glaucoma. And after 4 years, you can find progression, widening of the defect width. So we can also detect progression with RNFL photography. However, in myopic eyes, this kind of clear RNFL defects are not frequent. So this is case number 1, 28-year-old lady, quite young, with IOP21 and highly myopic. So quite strange optic nerve head and peripapillary change. And you can see some suspicious RNFL defect in inferior temporally. And OCT can clearly see those defects, and it can clearly tell us. And also at the macular area, you can see the superior and inferior difference, asymmetric ganglion cell layer change. Visual field is like this. So it is quite young lady. So some may think it does not change. It is due to the elongation of myopic change during the adolescent period. However, if we follow this patient for 10 years, it is progressed. So this is a myopic glaucoma case. It's not myopic optic neuropathy. And Japan group has shown that in highly myopic eyes, papillary macular bundle defect is quite frequent. This may be related with the tractional stress on the optic nerve head and lamina cribrosa in the temporal part of the disc. And also, if we are using glaucoma hemifield test to diagnose glaucoma, similarly, we can use a GC-IPL hemifield test, and we can compare the superior and inferior ganglion inner plexiform layer, GC-IPL layer, and we call that the temporal rapid sign positive. And also, we need to differentiate the red disease pseudo abnormal RNFL defect because of the shifting of the superior and inferior bundle thickness into the temporal side. So it is common in both in Asian and European eyes. So this is a healthy myop case, minus 6.5 diopter. And you can see the thickness curve, superior and temporal thickness curve shifted temporally, and it touches 5% normative database and 1% of normative database, and it creates red disease like this. It is normal myopic, healthy eyes. So we need to look at the thickness curve in myopic eyes, whether the curve is shifted to temporal or not. So case 2 is a 40-year-old lady, myopic, and RNFL defect was shown in the deviation map. We need to look at the thickness curve. So superior part, it is due to the shifting of the superior solid line to the temporal side. So it is red disease. However, inferior temporal RNFL defect, which is also shown in the RNFL photography, it is real defect, and it can be confirmed by the GC-IPL deviation map. We call that temporal rapid sign. So back to this slide. The strength of the temporal rapid sign is it is free from false positives associated with normative database, poor normative database, which not include the highly myopic eyes. Another study was to compare the temporal rapid sign in, in highly myopic eyes, including glaucoma and non-glaucoma cases, and AURC GCIPL hemifield test was 0.938. It is better than average RNFL thickness and average GCIPL thickness. Another part is we can measure the neuroretinal rim with OCT. So BMO MRW measures from the BMO to the internal limiting membrane in spectralis OCT. Same concept is in serous OCT called that 3D neuroretinal rim thickness. So in healthy myopia and myopic glaucoma, we compared RNFL thickness and this 3D neuroretinal rim thickness. So the left graph is RNFL thickness. It cannot differentiate glaucoma with red disease. However, 3D neuroretinal rim thickness can clearly differentiate red disease from glaucoma cases. Another one is we need to remove the confounding factor like systemic factors in our body. So if we compare both eyes with asymmetric axial lengths, we can only look at the factor axial lengths, and we can compare longer eye and shorter eye in one individual, and whether the eye is severe in glaucoma and whether the eye is faster in progression. So about 4.2% were the eyes with axial difference more than 1 millimeters, and among them 95 eyes, 95 individuals were included in this study. And their baseline intraocular pressure were not different between longer eye and shorter eye. And also, longer eye showed a larger beta and gamma zone peripapillary atrophy, and longer eye showed higher ovality index. An interesting finding was RNFL change per micron per year and GCIPL change micron per year was faster in longer eyes compared to the shorter eye. So this is the case with longer eye showed significant progression in RNFL GPA analysis, and also in RNFL analysis and GCIPL analysis, GPA analysis. So the conclusion, when the axial length difference is more than 1 millimeter, glaucoma tend to be more severe and to progress faster in the longer eyes. The last one is we investigated whether the intraocular pressure reduction is related with the slowdown, the progression of highly myopic glaucoma. It's a 12-year follow-up study. And also we want to identify which risk factors are predictive of progression of glaucoma. The result is disc hemorrhage was the significant risk factor for the glaucoma progression in highly myopic eyes. And percent reduction of IOP showed borderline significance. So we divided the upper tertile group and lower tertile group. Upper tertile is percent IOP reduction from baseline is more than 23.3%. Lower tertile was IOP reduction less than 11.1%. So upper tertile, large amount of IOP reduction group showed significantly greater cumulative probability of non-progression compared to the lower tertile group. So in summary, for diagnosis and monitoring of glaucoma in myopic eyes, disc hemorrhage and RNFL evaluation are important. It is crucial to differentiate red disease from true defect by reviewing RNFL thickness curve. The combination of peripapillary RNFL analysis and macular GCIPL analysis may enhance diagnostic ability. minimum rim width can complement RNFL thickness measurement in differentiating myopic glaucoma from myopia. Glaucoma tended to be more severe and to progress faster in the longer eyes. IOP lowering treatment may slow down the myopic glaucoma progression. Thank you for your attention.
Thank you, Professor Key. Any questions from the audience? I have a question. If there is a patient who's, I mean, how do you bring down the IOP in a myopic patient who's progressing? Is it on medical therapy, or have you had to do surgery also in some of these cases?
Yeah, in case of maximum medical therapy, if they progress, I do surgery. But in myopic eyes, trabeculectomy is quite problematic, but we do surgery
Also,
carefully.
yeah. Thank you.
I also have
Wonderful experience and talk. 2 questions. One is, in highly myopic eyes, the corneal hysteresis also is different. So was that a confounder in measuring IOP? Although I understand the same eye was measured pre and post, but was that a confounder which was taken care of? And second question is, what is the response of SLT in myopic eyes as a treatment modality vis-a-vis non-myopic eyes?
Okay. Yeah, I think the corneal property is very, very important. Corneal biomechanical property may be related with the optic nerve head lamina cribrosa
Lamina cribrosa,
biomechanical property. So in those myopic eyes, every myopic eyes are not glaucoma. Some of them are glaucoma. They have higher risk. Why? We don't know still exactly, but as you said, that kind of biomechanical property, susceptibility in highly myopic eyes and myopic eyes are associated with glaucoma development. So that may be related why East Asian eyes, Korea, Japan, and China, they have more susceptible optic nerve with very small elevation of IOP. So that may be related with.
Is that thinning of RNFL? I'm just thinking long term. We are seeing an epidemic of myopia. Is that thinning of the RNFL because of this biomechanics of the lamina cribrosa, let's say, extrapolating the corneal biomechanics? Is it going to cause a functional damage in the, not only the visual field, but in the functional, let's say, the ERG or the other aspects? Or is it just a thinning which is being reflected in the perimetry because that's geared up to think of thinning as damage? I'm just putting a question on that point.
Yeah, the thinning itself is, I think, they appears first in our
Yeah, so-
experience, and then we follow them, their visual field changes.
Is it damage or is it thinning?
Yeah, their ganglion cell is
Yeah.
lost.
Is lost.
So I think it's damage at
Right.
the lamina cribrosa.
And the SLT part?
Oh, SLT. Yeah, we also do SLT if the pressure is high teen. But in case of low teen, SLT, it is not working quite good. So in high IOP,
But does it work
high teens.
differently vis-a-vis non-glaucomatous eyes? That was my question.
Sorry?
SLT, would it work better in a myopic eye or a non-myopic eye?
Oh, we did not compare. We need to do that
Okay,
in
thank you.
perspective.
Professor Koot, you have a question?
Keho, it's always wonderful to hear you talk on this. And obviously, glaucoma, we think of it as a trabecular meshwork disease in a sense to start with. But myopia has sort of 3 different types of disc. The sort of hypoplastic small disc, the sort of relatively normal, and then there's the macro disc. Do you get any sense of whether the risk is different for the disc anatomy, the underlying disc anatomy? Is it people with the small disc? Is it people with the macro disc? Is it related to how much peripapillary atrophy is there? Do you have a sense of that?
Yeah, very good point. Myopic eyes usually have larger discs because originally or because of axial elongation, it may stretch. The disc is, the lamina cribrosa is thinner, and it may increase susceptibility to damage mechanically. So that's our speculation, but we need more information.
There are myopes, though, with small discs. With quite, well, we see them. I know
At the beginning.
Yes, no, those quite hypoplastic and small discs.
I think hyperopic eyes are small. Small.
Mm.
But,
Sometimes.
I promise you, we have had them.
Really?
Yeah.
So it may be there may be racial
that's right, it
differences.
might be differences in the
Asian
causation.
eyes has large
Yeah.
disc,
Yeah.
and Western eyes have smaller disc. So maybe that affects.
I'm not
Yeah,
so
I have a
sure.
question. You showed that the glaucoma progresses faster in eyes which are myopia. Have you seen the other way round? That in myopic eyes which have glaucoma, the myopia also progresses if the IOP remains borderline controlled. Because we do see a lot of our GOAG patients who have myopia which progresses
Mhm.
if the IOP is in the borderline range,
Yeah.
even in the adults.
Right. If the myopia progresses, like in pathologic myopia, it may increase their
Due to
susceptibility.
effect of IOP.
Right.
Yeah.
Right.
Any other question? Yeah.
When the posterior staphyloма is away from the disc, the disc appears small. That is one speculation.
Yeah.
Why the disc appears smaller, because the posterior staphyloma sometimes it's away from the disc, or when it is involving the disc, they appear larger. So
I guess the-
usually it is larger, but
Yeah.
when the staphyloma is away,
because, it's a
it's being
offset.
pushed. Yeah,
If at the beginning the disc is round,
yeah.
and if the axial elongation,
Then it is
the
pushed
BMO
towards.
changes,
Yeah,
and the laminate moves and BMO, they're offset. So the actual, by photograph, the disc looks small,
yeah,
but actually
yeah.
it's not small.
And I need a question to you, sir. How do you monitor actually? I think no investigation is reliable. Every OCT, HPF, everything has its own plus and minus. But how do you in general monitor them with one single investigation, or you have OCT-A also in your list of investigation for
Yeah,
perioperative
we monitor by all modalities: photograph, OCT, visual field.
at every visit?
Right,
Okay.
right.
Thank you. I think thanks to all the speakers and the delegates, and to my co-chair, Dr. Shikha. We had a great session. Thank you all. Thanks.
Thank you.